Hello and welcome to another episode of Everything Digital Health. I'm Marcus Bohr, I'm your host, and we're here to talk about digital health things. Something that's happened in the news in the last few days is that Ming Tang, the Chief Digital and Information Officer of NHS England, has announced her departure. And I know a lot of you will probably be aware of my existing position on things like the Federated Data Platform, and you might be thinking, well, that's a great time to put the boot in, Marcus. I'm not going to do that. Firstly, I have no interest in upsetting an individual or particularly criticising that person. I debated Ming Tang at length in numerous platforms and events and things. I've been on the same stage as her and talked about the Federated Data Platform and in particular its award to Palantir. And let's face it, there are many facets to this issue. Palantir is just one of them. There are very big problems with the Federated Data Platform, which are just about its existence and its lack of apparent function, its general expense, the issues of having such a large amount of data essentially directly in the control of the government, which I think recent events in the United States, which I'll link to, show quite how dangerous that can be. What I'd like to do today is just really quite quickly just whiz through some of the issues that this brings up and actually some of the opportunities, really, because we've got a few departures within NHS England, and that means that they've got to replace them. Okay, so here's the article on digital health, which is a news site that obviously focuses on this area, and it just really talks about Ming Tang leaving after 16 years. I'll link to the article so that you can read it, but I think interesting that Sonia Patel is also leaving, and at the top I think it says that John Quinn is also leaving. So we've got a lot of people leaving at the top, which I think potentially means that there's an opportunity for some new ideas there. Ideally some people with a little bit more, say, technical delivery experience. We can't build a modern digital first NHS on strategies and hand waving, and I think that too often we've got a preponderance of people at the top who really can only offer that, and at some point you have to just go and build something, and outsourcing everything, procuring everything is what has got us into the problems that we have with largely dysfunctional systems in our hospitals, not really the exciting digital future that is described in the 10-year plan. If we want to get to where the 10-year plan needs us to be, there is a way to do it, and it is to start to in-house some of these things. So it means a change of approach. It means that the Federated Data Platform should be in-housed. That will also give us a lot more control. Firstly, it will get rid of all the issues about Palantir. It will enable a layer of transparency to come in that we, as the community that drives the NHS, will have a little bit more say on exactly how it's implemented and exactly how it functions. So that's low-hanging fruit. We know from when the spine was in-housed that saved a lot of money. So it's definitely a thing that we should be doing. I think it's worth probably pointing out that back in 2021, when the Federated Data Platform was originally suggested and it was still not awarded to a particular contractor, there was a body of opinion that was very strongly against Palantir winning that contract. And it's sad that as a procuring organisation, NHS England has to have some degree of dispassionate assessment of the potential contractors that it could use. There is a point at which a contractor is so obviously totally unsuitable to be working in healthcare that somebody has to speak out. And really back then it was just myself and Foxglove and Med Confidential that were saying this. I think in the intervening years it's become a lot more obvious that Palantir are bad news in terms of a company that is quite happy to do whatever is necessary to, as Alex Karp puts it, scare and kill enemies, which is quite terrifying as part of your healthcare service. That's the lengths that they're willing to go to as a company, and they have no ethical qualms about that. Ming Tang at the time didn't get involved in any of these ethical discussions, and was obviously clearly happy for the contract to be awarded to a company like this. Now, at the time, I'm sure the NHS board would have been reassured directly by Ming Tang about the choice of contractor. That reassurance probably doesn't ring quite as solid now that you've got articles about Palantir using their technology to support essentially illegal detention and very unethical treatment of ordinary American citizens in many cases in the United States of America. And that is happening right now. And I think even if I were a member of the NHS board that had been reassured back then, I would be asking serious questions about the suitability of Palantir as a partner for the NHS. What I'll do next, I'll show you Alex Karp talking to his own shareholders quite openly about this stuff. Here's a clip of Alex Karp, the CEO of Palantir, talking to retail shareholders. So this is not the military audience he's talking to about killing people. This is ordinary shareholders that he is exhorting to agree with him about. I'm showing you it on the actual YouTube site rather than taking the clip and splicing it into the video, because I want you to see that this is actually public. They don't seem particularly embarrassed about it. They don't seem to think that this is a problem when working in the healthcare sphere in another part of the world.
Of our success in the US and globally, also, we are doing in the United Kingdom and many other places. Palantir is here to disrupt and make the institutions we partner with the very best in the world, and when it's necessary, to scare enemies and on occasion kill them. And we hope you're in favor of that.
Well, I'm not in favour of that. I'm not trying to suggest that we don't have any need for defence technology companies, but I think they need to stay in their lane. If part of your business is killing people and detaining immigrants with very scant regard for the law, there is a market for that kind of thing, but it disbars you from being part of the NHS, in my opinion. And I think that's probably an opinion that's shared by quite a few clinicians and quite a lot of patients. I'm going to share some footage of Ming Tang talking to the NHS board in 2023, which is interesting, just very interesting to listen to that whole section. But in this case, I want to just focus on one thing that she says, which is, I'm afraid, misleading. And it's very important that whoever's on the NHS board knows that this is misleading. So here, Ming has delivered about 5 to 10 minutes of general update on the federated data platform. But here she comes on to talk about public engagement, which very much sounded like a lot of broadcast and telling the public what they're going to get rather than listening. In this specific instance, there's a factual inaccuracy, which I think is very important to make more widely known.
That for direct care, they don't, it's not in their interest to opt out. Obviously they can, but it's unlikely. For secondary use, once we explain what we want to do, patients have been very supportive.
I think what I would say there is, firstly, you can't opt out of direct care. There is no mechanism to opt out of direct care, and there would be obviously no point in opting out of direct care. You want the data. In fact, the data must flow in order for you to have safe direct care. So there is no facility for federated data platform opt-out of direct care. There may be facility to opt out for secondary use of data, so that's things like research and planning, but the program has been trying to undermine some of the existing opt-outs that are already there. So it's worth just being aware that this is not quite as being laid out here. I also think that there is a slightly disingenuous narrative that's gone around the FDP, and it's also circulating around the single patient record, which is once we've got this tech in place, you will not have to repeat yourself around the NHS. And while there is some kind of repetition, which is bad repetition, I've talked about this in other videos, talking about repeating yourself as 100% a bad thing is nothing short of health tech populism. To explain what I mean by that, when you as a patient see a doctor, they might ask you questions that you've already answered somewhere else. But that is part of how we develop a rapport with you. That's part of how we make sure that we're talking to the right patient, for example. It's almost kind of a small talk type of thing. Now, what you don't want to be doing is repeating enormous tracts of your medical history or having to have tests done again because they are only present in another organisation and you can't get that record. That is not going to be solved by the FDP. And although the theory behind the single patient record is that that would solve this problem, the single patient record does not yet exist, has not been specified, has not been awarded to a contractor yet. We do not have the solution to complete data portability across the NHS. And even if we did, you would still sometimes need to repeat yourself for very good reasons. Because sometimes we ask you twice which kidney you would like to be removed. Sometimes we ask you 10 times which kidney you would like to be removed, because we want to make sure we remove the correct one. So I'm very, very conscious when I hear people like Wes Streeting saying, when we've sorted out the health data, you will never need to repeat yourself across the NHS. And they do use this quite a lot, as in they invoke the idea that it's inconvenient and it's annoying for patients to have to repeat themselves. And I would actually push back strongly on that and say it's done for a reason. Obviously, I would like to see complete data portability across the NHS so that you would never have to have a scan done again or a blood test done again because we already have the results somewhere else. That's great. And we shouldn't be using patients as a way of transmitting information around the NHS that should go from clinician to clinician or from organisation to organisation. Again, better tech can solve that one, but there is little evidence that the federated data platform or the single patient record will actually solve those problems. What they will do is spend an awful lot of money with some very big companies and create that zone of warped reality that multi-billion pound contracts often do. When £1 billion has been spent on something, the result has to be good, right? Because no one who's involved in procuring that system or commissioning it or who's part of the responsibility chain can admit that it's not good. So this is how we ended up with a system in the post office that cost billions, that is patently not good and caused harm, death, and innocent people to go to jail. But no one could say it was a bad thing until ITV broke the story, because multi-billion pound contracts warp reality. And I would say that's what's happening with the federated data platform. That is what's going to happen with the single patient record. Going to round up a couple of press articles just to sort of add some context to this. And I'm aware that I'm talking a lot about Palantir here, and the story is Ming Tang. As I've said, I'm not here to bash Ming Tang, but I do think that Palantir was a mistake. Here we've got a Guardian article in which Louis Mosley, the UK chief of Palantir, accuses UK doctors of choosing ideology over patient interest in NHS data row. And that's absolutely a false dichotomy. What he's saying there is you either act in your patient's interests, which means using Palantir, or you defend an ethical stance, and that's going to harm your patients, ignoring the fact that there are many ways of doing both. You can defend your ethical stance and look after patient interest simply by procuring your federated data platform through a company that doesn't have these ethical challenges. So this is the same Louis Mosley who didn't turn up for this high-profile Palantir and Foxglove debate. And I was able to find the actual photo that we took, because this was a debate that I was in. And myself and Corey Crider from Foxglove, we wanted to talk to Louis Mosley about how the contract was awarded. There was an evening soiree with watermelon cocktails, at which senior members of the UK government were present at that. Louis didn't come, so we brought a cardboard cutout of Louis. But this is what Palantir is up to now. So 2026, they have an app. There is a significant body of opinion that feels that, ICE does not have the remit to be doing what it's doing, and it is acting illegally, and it's being used as a form of intimidation and undermining protest. That's something that Palantir is doing in America, and to some extent the NHS is now complicit with that. So the people at the NHS board might be looking at this with surprise, as though this was not predictable back in 2021, 2022, 2023. It absolutely was. And I was saying this all the way through that period. Nobody was listening. I hope they're listening now. And I hope that the departure of Ming Tang gives some breathing space to let us review this situation. So moving into the future, let's look at the opportunities that this creates. We know that there are 3 senior people at least leaving NHS England. Now, NHS England itself will cease to exist in 2027, but the point being that these people that currently do those roles will need to be replaced, and that provides opportunity. It means that we can get some new thought processes into this system. Sometimes when a mistake has been made and £1 billion has been spent, you can't be the one that points that out if you were the one that created the situation. So the next person in post can look much more dispassionately at what's been happening and can actually review the situation and say, we don't want this to continue. We're going to re-procure. And I think that would be a perfectly reasonable thing to do. So overall, it's been a big piece of news. I don't think it's terribly surprising, to be honest. We've got a lot of people at the top of NHS England moving on. I think it represents opportunity. It means we can get maybe an open source agenda can start happening at the top of NHS England. Maybe we can start getting value for money out of our suppliers. The opportunities are wide open, and I'll link to a really interesting video from a guy called Nate Jones, who's a YouTuber talking about AI and strategy, and really interesting stuff about where the bottlenecks are now. And actually, the way that agentic coding has opened up the capability of building software means that you can build high quality software at scale in really absolutely incredible timescales. This stuff can be shipped very, very quickly. And he talks about Anthropic shipping the new feature in Claude, which is the Claude co-work feature. That took them 10 days and a team of, I think, 4 people. It's now incredible what can be achieved. And we in the NHS could be leveraging that. We need those people in that top role who understand it. They need to be able to understand vibe engineering. They need to be able to understand the clinical domain. They need to understand the technical domain. I'm not saying this is all one person, but what you want is those skills to be represented right at the top and listened to by the board. And yeah, we've got legacy to deal with. And if you understand how that legacy came about and what it's composed of, that can be dealt with absolutely fine. Some of it we just leave in place. Some of it we replace as needed. When necessary, we can be the drivers building new digital technologies directly for the NHS. We're a trusted brand. So that means if we create open source packages, if we create tools that we can share with the rest of the world, they will be used because people will say, well, NHS built it and shipped it and is sharing it with the world. That promotes us as UK PLC, providers and creators of high quality healthcare technology. It's all there. We will not get that though from buying stuff. We will never own it when we buy it. We will only ever be the procurer. But if we in-house this stuff, we can get better stuff for less money. And so the real important thing is that the bottleneck has moved. What used to be the bottleneck was the development and building the tech. And that has now collapsed. The amount of time it takes to build this stuff has reduced significantly. It's not reduced to 0, but it's reduced significantly. We are in a position at a really exciting moment to take this forward. And I think there are 3 appointments that need to be made at the top of NHS England. I'm sure there'll be interim appointments because that's what they always seem to be. It's a really exciting opportunity to get someone in there who is going to make a change instead of just doing the same thing. In the end, we've been doing pretty much this for 25 years, procuring things, and then we're wondering why what we've procured doesn't do what it should do, why it isn't joined up, why it doesn't have the standards that we need, why these systems don't talk to each other. Simple. We've been procuring them rather than owning them. And in the same way as people tell you you should own your house, not rent it, owning the software gives you a lot more control. Whilst we're talking about rented software, just one little point about when we're using software that's essentially come from another country is that we're suddenly, in the new world that we live in now, this Trump season 2 world, we are much more aware that if the Trump administration decides that you can't use a piece of software for something like, say, a sexual health clinic or an abortion clinic or contraception clinic, and they instruct all their US tech companies to enforce that, then we might find ourselves unable to deliver some of the clinical services that we want to deliver, even though no one in our country has passed any legislation to ban those things. Another country can have this effect on our healthcare system. So there is a really important thing here around healthcare sovereignty, and that comes from digital sovereignty. And I think the European Union are starting to get the memo on this, and they've realised that the last few years have been quite instructive. We need a Euro stack. We need these pieces of software to give us a certain amount of insulation and independence from American corporations who might change the rules at a moment's notice. And because everything's hosted, if they decide that we're not allowed to use software for a particular purpose because there's been an ideological change within the American government, overnight we won't be able to use those systems. And so it's really important that we have our own. Open source is a defense to this as well. I know you're probably sick of me banging on about open source, but with open source, you always have access to a copy of the source code. So even if the company that produced the software goes bad, you can fork that code base and you have everything that you had at the point that the fork happened. And if you want to develop that separately, you can continue that development. But closed source code, hosted systems, and being completely dependent on American mega suites is a very dangerous place to be in 2026. Okay, so I'm sorry if that has been a bit disjointed and rambling, but I did think it was worth marking the occasion of Ming moving on, and I wish her all the best of luck in her future career. I'm very excited about the possibility that this is going to create some new opportunities within NHS England. NHS England will be folded fully into the Department of Health and Social Care in the next few years. But that aside, the right people could get in there and could really transform what we can do in healthcare technology. It's all there now as well. Development is no longer the bottleneck it was. An in-house tech team at NHS England or Department of Health and Social Care could absolutely smash this and could be putting out some of the best software and some of the most joined up solutions that suit patients and clinicians alike. So, well, let's hope that that's what happens. I'm moderately confident or moderately hopeful that that could happen. I mean, we always have the concern that it isn't what's going to happen and that there'll be some further regulatory capture that happens. But let's keep campaigning. We get the NHS that we deserve in many ways. So if we are the ones campaigning for a good NHS running good software, built by good people and benefiting the rest of the world if necessary, that's what we'll get. We've just got to push for it. Thank you for your time, and hopefully this has been a nice quick update and not a too long one. And I'll see you in the next one.